So for those of you who missed the lunch session, this was most interesting. We had one of the folks actually do a cropping thing by himself. I'm very proud of him. That was great. So this is a full volume for core triatry atrium. I'm basically going to follow the same order. I'm going to start with core, and then I'm going to go to sort of, in this patient, I'm going to show you how you could evaluate the mitral valve itself, and then we'll go to a supravalve ring. Then we'll talk about mitral stenosis, and then subaortic stenosis. And about 8 o'clock, we'll stop. All right. So this is a full volume. I've already cropped it, and I've done all of my image manipulations to it, and so on. So just for the sort of for the 2D world, that's kind of the way that that looks. And really, there's not much that we're going to be learning from this. It's just a beautiful demonstration, so I just wanted to show you that more than anything. So to start with, I'm going to basically invert this image and cut off the other half. So now we're looking, instead of looking from left to right, we're looking from right to left. So this is like a right anterior oblique angiogram, if you will, like an RAO view. So this is anterior mitral leaflet, posterior mitral leaflet, the left ventricle, the LV outflow tract, and the aorta up there, and that's the membrane. And those are the, watch when they come into view right there. You see, those are two left pulmonary veins coming into the core, into the sort of the upstream part of the thing. And then over here, you're going to see another hole there, and that's the origin of the left appendage. On that, you have to believe me. Then the next thing I'm going to do here is, let's uninvert this. Yeah. And I'm going to start out by just showing you what this looks like from below if you just went above the above the mitral valve completely, and then we'll give back this side of the thing so that we're looking, en face at the membrane. And what you see is right there you see a gap. So it's very similar to the one that Dr. Sanders showed you. In terms of the specimen, that the gap, that the orifice of this is sort of posterior and leftwards, lateral. The next thing in this heart is sort of what you want to do with these is you want to do a comprehensive evaluation of the mitral valve itself. Eyeballing it, it looks fine, and it will turn out to be fine. I'm just going to show you how one would go about evaluating it. So to start with, you basically cut off the top of the heart, and now we're going to look down onto the mitral valve from above, and we'll give back this side. So now you're looking at the mitral valve en face from above, left atrial view. Now it looks a bit overgained, so you're going to have to constantly keep tweaking this thing. But all of that is the anterior mitral leaflet. This is posterior mitral leaflet here. It really looks pretty good from there. Then when we turn it around and look at it from below, you'll see the papillary muscles inserting, and then the orifice of the valve. So all of that also looks fine. And then a view that I've very much enjoyed is actually to look at the valve from the front. So we're going to cut off the septum now, and then we're going to look down onto the mitral valve like that. And this is a very unusual view. It's difficult to kind of replicate this view by other techniques or something. But what we've done, we've cut away the septum. These are the leaflets of the aortic valve. That's the root, the aortic root and the ascending aorta. And this sheet over here is the anterior mitral leaflet. It's the aortic surface of the anterior mitral leaflet. Okay? And there are two papillary muscles, and basically you see leaflets. So one of the nice little things about the normal mitral valve, it tends to insert, normal mitral valve has caudal attachments from both leaflets to both papillary muscles. So you see that here for the anterior leaflet. And if you wanted to keep cutting down, there, now we've cut everything away except for the posterior leaflet. So that's the posterior leaflet there, and you'll see it inserting into those papillary muscles as well. So this turns out to be a normal valve. The other thing to keep in mind with mitral valve issues is the LV outflow tract. So once again, we'll cut away the front and the top and the bottom of this, and look at the LV outflow tract from here, and that looks fine. All right. The next thing I'm going to show you is a supravalve ring. This was a kind of a complicated ring, and this was an interesting patient. It was a baby with coarctation of the aorta and this ring. Of course, inevitably also with subaortic stenosis and so on. And this was a big question because we had impressive gradients across this. Oh, there was a VSD as well. Impressive gradients across this ring. And the question from the surgeon was, do I resect that or do I just go after the VSD? And what I'm going to show you here, so this is a live acquisition. See, it's a pretty narrow wedge, but this is a baby. And so in a baby, a well-placed live 3D can give you a lot more information than you might think it would. Here are the two papillary muscles. So we are still going to need to do a little bit of cropping over here, just a tiny bit here. And now we are into the left atrium. You see, you don't really see the mitral valve opening very well. And that's okay. That's not really the goal of this particular sort of maneuver that we're doing. Now we're going to look from above. Let me cut this a little bit more. Yeah. Look from above. Watch now. So now we're looking down into the left atrium. See that? That's the mitral orifice there. Look at this thing here. If you watch, you'll see that there are two levels of restriction to the flow into this mitral valve. The first one is this business here. You see that line? That's a supra valve ring that is at the hinges of the hinge of the posterior leaflet there. But if you look down there, the leaflet, the orifice of the valve is still awfully small compared to what it should be like. So what's that all about? And that's something that you can tell by 2D imaging. I just think it's kind of cool to see it this way as well, like there. So that's one level, and that's the other level of this ring. That's one level, and that's the other level. You see that? It's like concentric circles, like a target. One here, one there. So that one and this one, right there. Now this patient also turns out to have pretty sad-looking, hypertrophied papillary muscles, short cords, and so on. So this was going to end up being a very, very complicated mitral valve repair. Besides, we had a pretty high gradient to flow, pretty impressive VSD to deal with. So the logic we came up with was, let's go after the VSD and see what comes up with the ring, because it did not really meet it was just going to be a massive problem if this was not going to be a straightforward ring. The straightforward one is going to be the one that's at the annulus that the surgeon can go in and excise and you're done. Here, if you cut, you're going to be left with this, and this is so far down that if you cut that, you might end up with holes in the valve and all kinds of stuff. Small baby. So left it alone and it worked out just fine. Next are some examples of congenital mitral stenosis. This one is one of my favorites. It's really a pretty ugly mitral valve. What you see here is that only the anterior leaflet moves. The posterior leaflet is just like a fibrotic. Watch the way this would look by 2D. Like that, right? So the posterior leaflet is immobile, and it's only the anterior leaflet that's really moving. And it doesn't open, it doesn't close, that posterior leaflet. Now we'll give this depth back, and you might wonder why we're doing that. And I think the answer is because you can look at it like this, the orifice of the valve, and then from above, you can see the cords. See the intercordal fusion. So you get a lot of detail. And if you have a surgeon who is planning to go in and do, the kind of fine work that is going to be needed in terms of fenestrating this subannular, it's all sort of below the tips of the valve. So they're going to have to go into the left ventricle to work on this, mitral valve. That's looking at it from above, right there. So there's the orifice of this mitral valve. All of this is the posterior leaflet. It is just completely immobile. This valve opens like a monocusp valve. Then a couple of other examples of congenital mitral stenosis that I thought were really fit in well with the kind of specimens that that Dr. Sanders showed. So this one, we'll start out by showing you the way this would look with the 2D imaging, kind of like that. So the annulus looks okay. The leaflets and the cords are very difficult to distinguish, right? So now the question is, how is this valve opening? And one answer would be to put color flow, but we're not going to do that. We're going to just make things a little bit more complicated for ourselves, I think. So we'll start out by slicing off the septum, and then we'll also cut off the top of this heart, because what we want to do is we want to look at this valve as a sheet. So that's the back half of the sheet, and then slowly give back the front. So I guess I haven't cut off the septum enough, so that's better. So now you see there's one little orifice of this valve. That business there. You getting a sense for that? That part there is one of the orifices. And then if you look at this from below, you see how it just doesn't open towards the apex at all. It's not like a normal valve. Here, it just looks like a big old blind pouch opening into the LV. And the reality is, it's got these fenestrations. See there, it opens there, and so on. Near the commissure. And then the third one was even more disgusting. If you do a 3D echo and it looks like this, don't give up. Just don't. Drop your gain down to like something like this, and drop your compression down as well. And the way that I know to do that is because I've done this before, and there are experiments that you can do. They're very simple ones. You go up on your gain until it makes you feel like you want to throw up, and then keep dropping it until it feels right, and that's about right there. So now here's the septum, here's the mitral valve, and look at this. This is like a one hole, another hole, and a third hole there. See the spray, right? You can imagine a spray coming out at you, like it's like a sieve. Look at this baby's heart rate. It's 180. Frame rate, pretty good. Live 3D acquisition. In other words, you put your transducer on and you can, in the right patient, you can get something like this. Okay. So now if I tilt this and I look at it from above, it becomes really obvious what a crazy valve this is. So we're looking from the left atrium now. Look at this thing. That commissure is completely fused. The lateral commissure is completely fused. And the medial commissure is the only one where the valve really opens. So looking from above, that's what the valve orifice looks like. And it's way down inside the ventricle. It's multiple little spray type orifices. So this was one where, unfortunately, this baby was just terribly sick from this disease. And, we were very, very sure that the surgeon was not going to be able to, he's a great surgeon, but he was not going to be able to do much with this. And that's what turned out to be the case. So he ended up putting in a prosthetic valve and so on. And the baby is still alive, but it's just a sad situation. Okay, now I wanted to end with a couple of really crazy 3D TE images. This, the first one is on, this is actually, let me tell you this lady's story. She's an adult. She had subaortic stenosis. She went to a center where they don't do congenital heart surgery. They decided to go for her operation. They created a VSD accidentally. They left her with residual sub-AS. They damaged her aortic and her mitral valves. And so in her mid-30s, she was left with a prosthetic mitral valve, a prosthetic aortic valve, a VSD patch, and sub-AS, subaortic stenosis, which is what she had presented with before. And she came back to us a couple of times after that because she had paravalvular leaks. around the prosthetic mitral valve. And she was transfusion dependent with hemolysis. So the question was, where, and we put in 2 Amplatzer devices and so on. And the question here was, is there another problem? Because we could see, as you can imagine, by 2D color flow and all, we were not able to understand anything about how much, there was MR, there was new AV valve leak, and she started hemolyzing again. So there was no question there was a problem. She was not a surgical candidate because she's had too many other things going on. And so the interventionalist decided to go in and see if there was another paravalvular leak that could be closed with a device. Okay. So here we are guiding this. So this is the catheter going into the left atrium. We're looking at it. So this is the plane of the atrial septum, you see, and that's the appendage over there. That's the base of the mouth of the left atrial appendage. This thing here is a transseptal sheath. And the catheter going from the right atrium into the left atrium curves around there, and watch, there's her St. Jude's prosthetic mitral valve. These 2 things here are Amplatzer devices right next to each other. Okay? See the bileaflet opening away from you? It's beautiful, right? But now, so those were not the problem. Look at this catheter. It's going in straight between the 2 discs. That's not a good place for it to go through. So we encourage our interventionalists to pull it out. And then watch what happens right there. So over there, it turns out, and I'm not going to open up the second thing to show you this, but she had dehisced her valve over there. There was a complete gap over there, and so she ended up having to go to surgery. We were not able to kind of stall that. And then a subaortic membrane. So this is a circumferential subaortic membrane. You see it from looking at it from below. There, below the aortic valve, you see it there and there. And then I've got a PowerPoint couple of slides to show you, and then I'll be done. This is a different patient with subaortic stenosis. This is the TE that we did. He was a big guy, 120 kilos. We weren't really able to get any surface images on him. We had some concerns about the mitral apparatus and so on. And here you can see this is very impressive, severe tunnel type subaortic stenosis. The valve itself looks okay, but this is long and ugly. And then we had a bit of a surprise. Look at this. This is a mitral valve papillary muscle cord that is attaching to the base of the anterior mitral leaflet. And actually, watch what happens in systole. It basically pulls it into the LV outflow tract towards the septum. Because of where it's attached, it kind of pulls it. So this is what Bob Anderson calls strut cords. So it's not a primary cord. It doesn't attach to the tip of the leaflet. They're important. They typically attach between the hinge and the tip, and they're important support apparatus for the normal mitral valve, especially the anterior leaflet. But in this case, this was just proving to be a very big problem for this guy. So our surgeon went in and he cut out all of this. He found this exactly where we suspected it was going to be, cut it out, and that pretty much that took care of it. And we were pretty sure that this was not going to result in mitral regurg because it was not a primary cord. Primary cord is one that attaches to the tips of the leaflet. And if it does that, when you cut it, you're going to get a flail segment. If it's secondary or strut, if it's attached somewhere else, you cut that, you're not going to get regurg. So there you have it. Ask him. He came to Charleston